نعم. هنبتدي الكلام في الجي اي بإذن الله تعالى، وكونوا بس معانا على الخط. توكل على الله.
Hepatic hemangioma.
Yes, and this is hepatic hemangioma, the giant type. You know that the hemangioma, when it is more than 6 centimeter in diameter, it's called a giant hemangioma. And the very small hemangioma that fills immediately after injection of contrast material is known as flash filling hemangioma, and the hemangioma in between is called the regular hemangioma. It's important to know that the giant hemangioma will not fill completely with contrast material, because usually the central part of the big hemangiomas is thrombosed. Next.
This meeting is being recorded.
Yes, what do you think of this case?
Hemorrhage, leakage.
Hemorrhage?
Leakage.
And the history is ligation of hemorrhoids, and you got a collection around the anal canal, and this collection shows air fluid level and marginal enhancement diagnostic of an abscess. Yes, and this is a perirectal abscess secondary to surgery. In this case, there is total history of total hysterectomy and adenexectomy or bilateral oophorectomy for endometrial carcinoma, followed by eradication 2 years ago. Then this is very minimal, and it shows what?
Fistula.
Between?
Rectum and the vagina, vagino-rectal fistula.
No, this is the ileum, and you see this is the ileum diagnosed by its small caliber and the absence of ostra, and this is of course the colon, and there is an ileocolic fistula developed from the previous surgery. Next.
Cholangiocarcinoma.
Yes, very good. This is a higher type of cholangiocarcinoma. There is dilatation of the intrahepatic biliary radicals in both lobes, and there is a soft tissue mass at the hilum of the liver, which is obstructing the ducts. Sometimes you got similar appearance when the lymph nodes in the porta hepatis are enlarged, but you can see that this lesion is protruding into the hepatic parenchyma. This is the hilar type cholangiocarcinoma, or what is known as Klatskin tumor.
Again, abscess.
Yes, whenever you see these surgical sutures, you know that there is a surgery here in the region of the rectum, most likely. And whenever you can see that the sutures are disrupted, they are not forming a continuous ring, then you know that there is some sort of anastomotic leak. And this is the cause of this collection, as well as air in the peritoneal cavity surrounding the site of anastomotic leak.
achalasia of the cardia.
Yes, and this is a straightforward case of achalasia of the cardia with sigmoid dilatation of the esophagus and tapering of the gastroesophageal junction with a smooth lining.
Rectal carcinoma.
Yes, and this is
Stage 3.
very good. This is a stage
Stage,
3 rectal cancer with invasion of the muscularis propria and extension into the perirectal fat, as well as there is an enlarged mesorectal lymph node, as you can see in this particular image. Yes,
Pancreatitis.
chronic or acute?
Acute.
Yes, acute pancreatitis with fluid around the pancreas, of course, is the sign of chronic pancreatitis is the presence of calcium within the pancreatic tissue. But here the pancreas is relatively swollen with fluid density around the pancreatic area, and this is diagnostic of acute pancreatitis.
Stage 1 rectal carcinoma.
Sorry,
Rectal carcinoma. Stage 1 or
Stage
2.
3.
Yes, stage 1 or 2. This is a stage 1 or 2 because of the intact muscularis propria. But this arrow points to a minimal invasion of the muscularis propria. And you know that stage 3 is divided into 4 sub-stages, including stage A, where there is minimal invasion less than 1 millimeter of the perirectal fat. And if the invasion is from 1 to 5 millimeter, this is stage 3B. If it is from 5 to 15 millimeter, this is stage 3B, stage 3C. Okay. Yes, what do you think?
Peritoneal carcinomatosis.
What about these calcium?
Cavernoma.
Hemangioma, you mean? Okay. Of course, whenever you see a lot
Hemangioma.
of
Hemangioma.
calcific philipoli in the pelvis, you know that these philipoli are present in hemangioma. And there is a type of hemangioma that can diffusely affecting the pelvis, and this is one of the examples of such a hemangioma, which is known as diffuse cavernous hemangioma, which is spotted by the presence of calcified philipoli scattered through the pelvis. And even if you look at the plain film and you see a lot of philipoli in the pelvis, you should suspect this possibility, since philipoli in the pelvis are usually 1 or 2 or 3 even, but too many philipoli are suggestive of hemangioma.
Hydatid cyst.
Okay, this lesion is a cystic lesion in a very characteristic location anterior to the sacrum, and I have
Villiform tumor.
sorry,
Villiform.
no, this is not inside the rectum. The rectum is compressed by the lesion.
Gall duct cyst.
Its name is tail gut
Tail
cyst.
gut cyst.
Yes, tail gut cyst is one of the lesions that arise in front of the sacrum or in the presacral area. It shows characteristically diffusion restriction. This is a rare congenital lesion seen mainly in females. Sometimes it is known as cystic hamartoma, exclusively found in the presacral area. It's not found anywhere in the body and can present at any age, but this is the usual presentation between 30 and 60 years of age. And 50% of the patient may have some symptoms like pain and congestion. You can see a cystic lesion. Sometimes you may see calcification, and the lesion is characteristically of low signal in the T1, high signal in the T2. Sometimes you got a slight elevation of the T1 signal due to the presence of protein contents or mucinous like material. Then the lesion showed diffusion restriction, and if you inject the contrast material, it will show heterogeneous pattern of contrast enhancement. The only differential diagnosis for this lesion is the presacral epidermoid cyst, which is also have almost or a nearby similar characteristics, and it also shows diffusion restriction. Okay.
hiatus hernia,
Which type?
rolling,
Yes, paraesophageal type 2 hiatus hernia, where the gastroesophageal junction is below the diaphragm, part of the stomach is above the diaphragm. If the gastroesophageal and part of the stomach are above the diaphragm, and this is type 3. If only the gastroesophageal junction is above the diaphragm, this is type 1. And type 4, if there is the gastroesophageal junction, the body part of the stomach, and other organs included in the hernia, and this is type 4. Yes. This lesion is very characteristic, and it can be a spot diagnosis. The rectum is distended by gel, and you got this appearance of filling defect, which simulates the carpet, and is very characteristic for. Okay, and this is villus adenoma of the rectum, or villus adenoma of the rectum. It has a very characteristic appearance, as you can see here. Okay, this is T1 and this is T2 of the pelvis.
Villiform rectum
Sorry,
of rectum. Villus form of rectal cancer.
in this case, and
fibroadenoma,
No, the previous.
neurofibromatosis.
yes,
Neurofibromatosis.
this is pelvic neurofibromatosis. There are multiple soft tissue masses with characteristic target sign, and this is diagnostic of pelvic neurofibromatosis.
Crohn's disease.
This is the rectosigmoid. Yeah, and you know the Crohn's disease and ulcerative colitis have the similar appearance on CT, but the difference is in the location of the lesion, and this is the site of predilection for ulcerative colitis. If this appearance is present in the terminal ileum, then you think of Crohn's disease.
stage 3.
Yes, stage 3 rectal
Rectal
cancer with mesorectal lymphadenopathy and extra mesorectal lymph nodes. Stage 3 rectal cancer. Yes. And this is a very mean study, and you can see that there is a bulboid filling defect in the gastric fundus associated with appreciable narrowing of the distal part of the esophagus. And what do you think? It has,
Sir, with shouldering effect.
yeah,
Shouldering effect is there,
yes,
doctor?
yes, and this is malignancy. There is almost no differential diagnosis for this because of the irregularity of the filling defect and the involvement of the distal part of the esophagus. And this patient had right upper quadrant abdominal pain and nausea, as well as weight loss. His age is 56 years old, and there is
Hepatic hydatid.
yes,
Hydatid
these are
cysts.
multiple hepatic hydatid cysts
Hydatid.
with the classic appearance of the big cyst with daughter cysts along its margin. Yeah, it's an easy. What do you think of this? Okay, and this is ultrasound of the
This meeting is being recorded.
وايه اللي حصل يا دكتور شريف؟
بيتهيألي الكونكشن قطع من عند حضرتك ورجع تاني. تعمل شير سكرين تاني. ما كناش سامعين.
كده خلاص رجع تاني.
هو ده كده الحالة اللي حضرتك واقف عليها بعد العدات على طول.
طيب.
Gallstone.
Yes, multiple gallbladder calculi with characteristic posterior acoustic shadowing. Okay. Next case. This female, 29 years old with acute abdominal pain. Okay, can you answer just more quick in order not to occupy too much of the recording tape? Then in such cases, if you look to the abdomen and you cannot see ايه ايوه يا مش عارف، ما عنديش مشاكل. أطفي الواي فاي.
أسهل يا دكتور.
طيب ماشي حاضر. اوكي، اقول لك اطفي الواي فاي ولعه تاني. هو شغال المفروض. ايه طيب كده انت معايا على الخط؟
تمام، سامعين حضرتك كده تمام.
طيب اوكي. And in cases whenever you are looking to the abdomen in a patient with acute
This
abdomen,
meeting is being recorded.
then if you do not see a significant abnormality, think of epiploic appendicitis. Then if you go through the abdomen looking for this appendicitis, you may see such a very small lesion with some thickening of the peritoneal fat, and at that time you can diagnose this. Then if you have a case with acute abdomen and you do not see a significant lesion in the appendix, in the pancreas, and so on, think of epiploic appendicitis.
gastric biswar.
Yes, and this is gastric biswar in a female 9 years old. She is anxious, complaining of upper abdominal pain and tenderness. This patient had acute pelvic pain during colonography, CT colonography.
Rupture.
Yes, and this is perforation of the rectum. In CT colonography, you may sometimes introduce some air in the rectum. Then you may by chance you can perforate the rectum. This child with acute right lower quadrant
Appendicitis.
acute
Appendicitis.
yes, acute appendicitis. And this female 33 years old with intermittent rectal bleeding.
Endometriosis.
Very good.
Rectal endometriosis.
Yes, and this is the classic appearance of rectal endometriosis, affecting the anterior wall of the rectum with serrated appearance, and endometriosis of the bladder affects the posterior wall of the bladder, and in the rectum it affects the anterior wall, of course. And this is the value of MRI showing how can endometriotic tissue can invade the anterior wall of the rectum. And this is ultrasound of the gallbladder showing
Gallbladder mud.
yes, this is gallbladder mud. And this patient with multiple hepatic focal lesions and a mass in the pelvis. What do you think?
Metastasis.
Of
Sigmoid cancer.
rectal cancer. This is the rectum, and
Rectum.
it was proved to be a carcinoid tumor, but you cannot predict that this is a carcinoid tumor. And you may, if you said that this is rectal carcinoma with liver deposits, you are right. And this patient had mastectomy and axillary lymph node dissection for breast cancer, followed by chemo and radiotherapy, complaining of abdominal pain and bloating. The CT scan of the pelvis showed diffuse circumferential rectal mural thickening.
Metastasis to the rectum.
Yes, and this is metastasis to the rectum. Whenever you know that there is a primary malignancy, you should think of the possibility of metastasis. Then this is an ultrasound and Doppler for a patient with recurrent fever, abdominal discomfort, cough, unresponsive to antibiotics.
Abscess.
Yes, and this is
Hepatic abscess.
classic appearance with internal echoes
Flame of air.
and some of posterior acoustic shadowing. And this is the abdominal CT showing a big mass in the pelvic abdominal region with proximal intestinal obstructive changes.
Lymphoma.
Yes, this is the
Lymphoma,
classic.
intestinal lymphoma.
Yes, this is the classic appearance of intestinal lymphoma, where you got a big mass with bowel loops inside, and this is sometimes known as the aneurysmal dilatation of the bowel loops. This patient had guest of the stomach that has been resected 2 years ago, and now
Metastasis.
Recurrence of
yes,
guest.
and there is recurrence of the tumor as well as hepatic metastasis. This patient is treated for suspected abdominal TB with no relief of the symptoms. He presented by crampy abdominal pain, recurrent diarrhea, and weight loss.
Tivus mesenterica.
No, there are no lymph nodes at all here in the scans. He was suspected to have abdominal TB, but is not suspected.
Ulcerative colitis.
No, this is a small bowel, not a large bowel.
Crohn's.
Crohn's, yes.
Crohn's disease.
And this is a Crohn's disease. Both lesions, Crohn's and ulcerative colitis, can produce similar CT appearance in the form of diffuse mural thickening, encroachment on the lumen, as well as reticulation of the intestinal fat and the engorgement of the related vessels. Then, if you are sure that you are dealing with a colon, think of ulcerative colitis. If not, think of Crohn's disease.
Fissure, anal fissure.
No? Fissure is not seen in the CT scan nor in MRI. With very difficulty to appreciate. But this is a fistula. Which type of the fistula?
Intersphincteric.
Intersphincteric grade. If there are no branches and no abscesses, this is grade 1. Okay.
Grade 1.
Yes, this is grade 2 because of. No, I think this is grade 1 because there is a straight line with no branches or related abscesses. Okay, sorry for this bad quality of the images, but this patient had persistent right lumbar pain. And then if you look for the reconstructed image, and you can see that this lesion is filled with gastrography.
Doctor, there is a mass in the right kidney.
Diverticulum, I think it's duodenal diverticulum.
This is duodenal diverticulum, and you see it very clearly in the barium. There is no masses, of course. This is a pre-contrast scan, but one of the important findings whenever you are interpreting abdominal CT scans, if you see a lesion that contains air fluid level, and even if you introduce gastrographin, it will show some gastrographin content. Think of a duodenal diverticulum. Yes, and this patient is suspected to have left adrenal mass on ultrasound.
Gastric tumor.
And this is gastric tumor, which is characterized by exophytic extension. It is intimately related to the gastric wall, inseparable from the stomach, so that you cannot consider it as an adrenal tumor. This is another type of the fistula. Yeah, please. And we have to decide between two, which are the most common, the intersphincteric and the extrasphincteric. And if it is in the intersphincteric position, look for the fistulous tract. If it shows side branches or loculi of collection, this is grade 2. If not, and this is grade 1. Okay. And this is intersphincteric fistula grade 1 because the single tract can be noticed. This patient is complaining of pelvic pain, and he has a remote history of abdominal trauma in childhood.
Stenosis?
Yes, very good. And consider if there is abdominal surgery concerning the spleen or abdominal trauma, and you got multiple solid enhancing soft tissue masses scattered in the peritoneal cavity, you think of splenosis. This is one of the lesions, and there are a lot of lesions in the pelvis.
Hydated?
Yes, multiple hydatid cysts in the pelvis and in the liver as well. This patient had metastatic colorectal cancer and acute renal failure with acute onset of abdominal pain and distension.
Spinal obstruction, large
Yes,
bowel
and this
external
is
obstruction.
intestinal obstruction with multiple air fluid levels. Many times you should have CT scan so that you may find the cause of obstruction. If you didn't find the cause, you consider it due to adhesions, whether this is post-operative or even in the absence of history of operation. But this scan showed the cause of obstruction.
Vagal volvulus?
Yes, and this is a small bowel volvulus or mesenteric volvulus, where you can see the worldly sign at the root of the mesentery, diagnostic of mesenteric volvulus with consequent intestinal obstruction. This is another type of fistula where it is also located in the intersphincteric area, but it has a horseshoe configuration, meaning that it has a side branch so that you consider it.
Grade 2?
Yes,
Grade
you
2.
consider it grade 2 intersphincteric fistula. If the fistula has crossed the external sphincter, then this is extrasphincteric, and its grade will be 3. If it is associated with branches or abscesses, this is grade 4, as you all know. Then this patient presented with internal hemorrhage.
Gastric tumor.
Gastric
Gastric
carcinoma.
Yes,
tumor?
this is gastric guests you see, this is a big lesion which is
Ulcerating, gastric
ulcerating
ulcers.
in the gastric wall. Yes, very good. This patient has heartburn, barium swallow, and CT.
Leiomyoma?
Yes, very good. Leiomyoma, because of the eccentric location in the wall of the esophagus, is not obstructing the lumen. This is not fistula, but
Absence.
yes,
Abscess?
the perineal abscess or perianal abscess, you got enhancement of the wall, and you got some loculus of air and the stranding of the perilesional fat.
Esophageal lymphoma.
Very good. And this is esophageal lymphoma because of the
Long course.
yes,
It's
the
long
long
course.
course and the submucosal spread, which is not obstructing the esophageal lumen in spite of the big and the bulk of the tumor. This is one of the characters of the esophageal lymphoma. And this is also a fistula, but the fistula has crossed now the external sphincter, so it is considered as
Extrasphincteric.
extrasphincteric. Then you look for side branches or abscesses. If not, it is grade 3. If there is grade 4. What do you think?
Grade 3.
No, there is a collection
Grade 4
here,
is small
and this
abscess.
is grade 4. Okay, this is a very characteristic lesion, but it's rarely encountered in the clinical practice and is known by its striated appearance and the big bulky mass in the pelvis, sometimes protruding from the vagina. Do you know this lesion? You know, it's known as aggressive angiomyxoma. And I have mentioned it
aggressive
in the literature, in the
lymphoma.
lectures. It's not common, but the appearance is very characteristic. And is you see it mixed of fat and other soft tissues with the classic striated appearance and the big bulk of the tumor tissue. Then this is a 17 years old female with painless swelling in the perineum, diagnosed as a perianal abscess,
Rhabdomyoma.
rhabdomyosarcoma.
Myosarcoma.
Yes, the
Rhabdomyosarcoma. Yes.
rhabdomyosarcoma is one of the tumors of the childhood, and this is one of the sites in the perineal area or perianal area, and of course there is it is included in the differential diagnosis also the lymphoma and the metastatic disease.
Gallbladder carcinoma.
Gallbladder mass.
Yes, gallbladder carcinoma. If you see a mass in the gallbladder, it is either a polyp or a carcinoma. If it is more than 1 centimeter, cancer should be considered until proved otherwise.
Coledocal cyst.
Yes, and this is colodocal cyst or the colodocal diverticulum, you may call it this, and it is also seen here. You see the common bile duct, this one, and the colodococele here. Okay, this is an extra sphincteric fistula with a huge abscess in the gluteal region.
Grade 4.
Grade 4. Okay. Severe abdominal pain after percutaneous nephrostomy.
Rupture gallbladder.
Perforation
Yes,
gallbladder.
rupture gallbladder or perforation of the gallbladder with the development of biliary peritonitis. History of multiple blood transfusions.
Hemochromatosis.
Yes, hemochromatosis or
Heme-
hemosiderosis of the liver and the spleen. Yes, we have mentioned this before.
Tail gut?
Yes, and this is tail gut duplication cyst in the presacral area with characteristic diffusion restriction.
Angiomyosarcoma
Very
or
good.
lymphoma or METS.
Yes. How can you predict that this is angiosarcoma?
The primary lesion, the primary tumor in the spleen.
But it is not that common as lymphoma, you know.
Okay, but you said before that we mentioned the primary, then lymphoma, then METS.
Yes, you are right. This is very good thinking, actually, and I hope that all of you can think like this. You think of the primary lesion, then you think of lymphoma and metastasis somewhere in the body. This will help you to reach the differential diagnosis easily. Then what do you think of this?
Hemangioma.
No? This is arterial phase, and this is portal, and this is portal also. This is T2.
Hepatocellular carcinoma.
No? And this is actually an abscess. Sometimes in the kidney in particular, you got the abscess made of multiple small loculi with marginal enhancement of each loculus. This lesion was previously known as carbuncle. And sometimes the abscesses in the liver, it's not that common. They have this appearance of loculi separated by enhancing septations. But commonly, the abscess is formed of one or two loculi with enhancing of the wall as well as the septum in between. Yeah,
Cirrhosis.
sorry, what do you say?
Liver cirrhosis.
Is not cirrhotic liver. You got a smooth margin of the liver. This is CT with contrast, and this is MRI with contrast, and you see a lesion here, which is let us say masked by the stomach, and this lesion showed the classic appearance of nodular marginal contrast enhancement in both CT and MRI, classic of a hemangioma. And there are multiple other small lesions that did not show any pattern of contrast enhancement. They are considered as simple hepatic cysts. Okay, this patient had abdominal pain after anterior resection of cancer colon 6 months ago.
It's foreign body.
Yes, and this is goosey or the retained surgical towel, and you can know that this is towel by the presence of air in the meshes of the towel, which is absent here, but the history of surgery and the bizarre appearance of the lesion can let you guess that this is a retained surgical gauze. And this is a patient with abdominal distension and urine retention.
Hydatid.
Yes, and these are multiple peritoneal hydatid cysts, not a small bowel obstruction, of course, because the small bowel is good, and these are peritoneal cystic lesions. Number one in the differential diagnosis and diagnosis is the hydatid cysts. This patient is diabetic with chronic renal failure, treated by peritoneal dialysis, presented by abdominal pain, tenderness, and low-grade fever.
Abscess.
Yes, and this is peritoneal abscess, big loculus with enhancing margin and internal air loculi. This is T1 and this is out of phase.
Fatty liver.
Yes, fatty liver or hepatic steatosis. This is the patient is known to have carcinoid tumor and multiple focal hepatic lesions.
HCC.
Yeah, no, is
Metastasis.
yes, the patient had the primary malignancy, then you should diagnose any lesion in the liver as metastasis
Metastasis.
until proved otherwise. And this is CT and T2 weighted image and
Pancreatic cyst.
this is diffusion image.
Pancreatic cyst.
If it is a simple cyst, it will show diffusion free.
Serous cystadenoma, pancreas.
Mucinous cystadenoma because of the mucin content in the lesion, which simulates the pus. In the abscess, it shows diffusion restriction.
HCC.
Yes, and this is a straightforward hepatocellular carcinoma with the classic appearance in the T2 and the enhancement in the arterial phase, wash out in the portal phase, delayed enhancing capsule in the delayed phase.
Diverticulitis.
Yes, and this is sigmoid diverticulitis. You got thickening of the wall, stranding of the fat, and multiple patent diverticuli in the wall of the affected sigmoid. It is T1, T2, arterial, portal, delayed.
Hemangioma.
Hemangioma, non-giant hemangioma.
Giant hemangioma.
Yes. This patient presented to the primary care provider with progressive abdominal distension over the past few months.
Pseudomyxoma peritonei.
Omental cake.
Omental cake, okay, but pseudomyxoma peritonei should have sections in the liver and spleen so that you can see the scalloping border of these two organs, which is diagnostic landmark of pseudomyxoma peritonei. But in this case, you can see ascites, you can see soft tissue thickening of the omentum, and you can see peritoneal masses. The differential diagnosis include carcinomatosa, lymphomatosa, and malignant peritoneal mesothelioma, as well as TB. But in order to reach the final diagnosis in this case, actually we go to the omental cake and we have biopsy. Then we can reach the diagnosis, whether it is metastasis or lymphoma or mesothelioma or TB. But this patient had an upper GI endoscopy where they detected the gastric mass, and the biopsy was primary gastric adenocarcinoma, so that the peritoneal lesions will represent metastatic deposits. So whenever you see an omental cake and the massive ascites, of course, and you go through all the abdomen looking for a primary malignancy, especially in the stomach, in the colon, or in the ovary, then you fail to detect this, and many times We go by biopsy to know to confirm the diagnosis and to know the primary malignancy, which may not be found by the CT images.
Stage 4.
Stage
2.
Stage 4.
Stage, this is stage 2, of course, because of the horseshoe configuration. Or you may call it, because of the collection is big, you may call it as an intersphincteric abscess, especially if it is not tracking to the perianal area.
Polyp.
Gallbladder polyps, the most common is cholesterol polyps. And you know polyps by the absence of posterior acoustic shadowing, and they are not mobile if you change the patient position.
Doctor, this polyp need follow-up?
If it is less than 1 centimeter, you may consider it benign, and the cholesterol polyps never turn malignant. But if it is a single polyp, then the possibility of adenomatous polyp may be considered, which is a precancerous condition and should be followed up.
No. Chronic pancreatitis?
No.
Pancreatic carcinoma.
Yes.
The cancer head of pancreas.
Yes, pancreatic head cancer, and you see a bulky mass in the pancreatic head obstructing the common bile duct, and the common bile duct is markedly dilated in this area with a dilatation of the intrahepatic biliary radicals. And this is pancreatic head carcinoma.
Hydatid disease?
Yes, these are multiple calcified hydatid cysts in the liver.
Paniculitis.
Mesenteric paniculitis, yes, and he got the fat ring sign around the vessels. This is classic appearance.
اقول لك حاجه، حسن مبارك في عز جبروته بتصوره في كل حته بس.
Yes.
Appendicitis appendiculis.
Yes, very good. This is an appendicalis, and this is the appendix, which is distended with the stranding of the periappendicular fat. This patient was suspected to have Crohn's disease, presented by left lower quadrant pain and diarrhea with weight loss. Abdominal CT to look for small bowel pathology incidentally showed
Cystic duct obstruction by stone and dilatation of the gallbladder.
I don't think that this is a stone in the cystic duct, but we can consider it like this, and the gallbladder is markedly distended. The diagnosis was right. You're right that there is a cystic ductal stone with dilatation of the gallbladder. Very good. Vague abdominal pain and malaise.
Air fluid leak.
This is a non-contrast study.
Hepatocellular carcinoma.
And this is the gallbladder.
Spinal obstruction.
No, this is the gallbladder, which
Gallbladder carcinoma. Gallbladder
which
carcinoma.
contains a mass or a soft tissue mass occupying most of the gallbladder lumen. And you know that mass in the gallbladder should be considered as carcinoma until proved otherwise.
Rectal carcinoma.
Yes, and this is rectal carcinoma reaching the mesorectal fascia, and this is considered the stage 3 D or C according to the classification. And if there is the tumor is reached the mesorectal fascia, this means that the prognosis of the tumor is relatively bad and the incidence of recurrence is relatively high. This patient had acute abdominal pain.
Look like
Picture the
a
appendix.
Perforated appendix, yes, and this is right. And this is appendicular perforation and formation of an appendicular mass, which is made of multiple loculi of pus as well as inflammatory granulation tissue. Sometimes you can find a calcified loculus within the mass itself, which represents the previously appendiculis obstructing the appendix. This patient had a long-standing HIV infection and is clinically controlled. He complains of epigastric pain, right hypochondrial pain, nausea, vomiting for 5 days.
cholecystitis.
Yes, cholecystitis, and there is some leak of the bile
Yeah.
around the
Yeah.
gallbladder, and this is perforation of the gallbladder. Okay, this is the